Hello, my name is Rijul,
My name is Abhinav.
and welcome to our project. Our project uses binary logistic regression model to classify risk of heart disease at a higher accuracy than an electrocardiogram.
I wanted to do this project in light of my uncle's death. He had heart disease and suffered from a heart attack. I wanted to create this model to prevent deaths such as his in the future.
My grandfather suffered greatly from a heart attack as well, and since then I have found it imperative to develop a program that more accurately predicts heart disease risk than the currently venerated ECG.
According to the WHO, heart disease is the leading cause of deaths worldwide, taking an estimated amount of 17.9 million lives each year. Physicians' interpretation of electrocardiograms is not even as close to reliable as they should be, based on both pre-training and post-training assessments.
Current risk prediction for cardiovascular diseases are based on the assumption that risk factors for CVDs are linear. However, this oversimplifies complex nonlinear relationships. To combat this, we used a binary logistic regression model, or BLR, machine learning model that uses a logistic function with the optimal parameters to calculate the probability of a certain condition being true.
So, our goal is to develop a highly effective BLR model that predicts heart disease presence at a higher overall accuracy and lower false negative rate than an ECG.
The first step was to find an open source dataset online and then clean it so that it would be usable for our machine learning models. We found a heart disease dataset on Kaggle created by UCI. We randomly shuffled the rows, each of which had a subject because they were in order by heart disease presence. Then we split the dataset into a training dataset with 2/3 of the data and a test dataset with the remaining data. Next, we created a program in R, a statistical programming language. We use this language because it has more statistical functions and better visual representations of data than all other programming languages, including Python. Following this, we performed exploratory data analysis, or EDA, to find which predictor variables are strong predictors of heart disease presence and the relationships between the predictor variables. First, we performed one-dimensional EDA to understand the distribution of each predictor. Bar plots show the distribution of qualitative variables, and side-by-side box plots show the distribution of quantitative variables based on heart disease presence. If the difference between bar plots or box plots for a certain variable is comparatively large, then that variable is a significant predictor of heart disease presence. Second, we performed two-dimensional EDA to explore the relationships between the quantitative predictor variables with the correlation matrix. If two variables were too strongly correlated with each other, then we would remove one of them from our model to avoid overcompensation for them.
Now, let's take a closer look at the cardiac cycles of a normal heart in comparison to one predictive variable of heart disease, ST depression. As shown on the top right, this dip in the ST portion of the cardiac cycle clearly displays heart disease, as blood flow is inhibited by plaque buildup during increased ventricular contraction induced by exercise.
After EDA, we trained our ML models using our training dataset. Next, we tested our models using the test dataset to find the accuracy and false negative rate of each model.
Finally, after comparing all ML models and finding the BLR model to be the best, we then compared that with ECG data gathered from research journals. The first chart shows a whopping 84 respondents out of a total of 212 were incorrectly diagnosed using an ECG with hypertrophic cardiomyopathy, which is a thickening of heart muscles, making it hard to pump blood, leading to diminished sports and extracurricular participation. The second graph depicts various heart disease contributors and their corresponding ECG interpretation efficacy, which is overall quite low. Two primary representations are normal heart and one with pulmonary hypertension, containing a 71 and 34% efficacy rate, respectively.
Here are our side-by-side box plots. Here are some of our bar plots. This is our classification trees model, which makes predictions on the bottom based on variable values along the path.
At the very bottom of the screen is one of our subjects. Some of the associated predictor variables include personal characteristics such as age and sex, while others include health characteristics such as cholesterol and ST depression, denoted by CHOL and old peak, respectively. Altogether, this variability in predictor variables will result in a more accurate and representative model.
These confusion matrices show the results of testing our models. The columns show the predictions by our model, and the rows show the real values for heart disease presence. The number of false negatives is in the bottom left box of each matrix. A linear regression model makes predictions using a line with optimal parameters, and a quadratic regression model does the same but with a quadratic. Here are the side-by-side comparisons of each model. The neural networks model was created by the International Journal of Engineering Research Technology using the same dataset as ours. Our BLR had a greater overall accuracy and much lower false negative rate compared to the other models. In comparison to the neural networks model, our model had the same overall accuracy, but a better sensitivity, which is the percent of true positives out of all positives predicted by our model. In addition, a BLR is more efficient in terms of time and memory than neural networks.
Thus, it is apparent that the BLR model is the most accurate and efficient model in overcoming ECG inefficacy. Using a voluminous number of 13 characteristics given by an individual, this program will accurately classify heart disease presence.
There are two minor errors we made and resolved. The first one was trying to use a dataset we found before the Kaggle one with only 30 subjects. However, these are not enough subjects to train our model accurately. The other error we made was to use too many predictor variables from the Kaggle dataset for a model. We fixed this through finding the most significant predictors using EDA and only using them for our model.
Being a 100% predictive model with no testing required, this program will produce results instantly. Further, model can minimize clinical visits, which seem unsafe during a time of COVID-19 where social distancing is advised.
Our dataset only had subjects from Cleveland, so in the future, data from different regions should be used to make more region-specific models. Newer versions of our model should also use less variables to allow fewer tests and improve efficiency. Finally, the presence of disease conditions such as CHD should be considered.
Here are references. Thank you so much for watching.